Hello, and thank you for coming to the RSNA 2022 Imaging AI in Practice demonstration. We will walk through the clinical scenario of the patient who has already been admitted for further monitoring and evaluation, giving concern for a stroke. My name is Albert Zhao, and I'm a radiology resident at Brigham and Women's Hospital, Harvard Medical School.
Hi, my name is Alicia Dami, a radiology resident from Stanford University.
All of you should recognize this as a PACS system. This demo will focus on the system which you are used to working with every day. In this case, this is a home station for the radiologist on call. We are focusing on the Visage PACS, which is cloud-hosted for this demonstration. Let's set the stage for our scenario. Upon waking up one morning, Frank, age 65, was feeling weak in his lower extremity. Frank underwent a CT scan in the ED, and there was no hemorrhage. The neurology team was concerned for stroke, and Frank was given TPA. After getting TPA, the neuro team ordered an MRI for further evaluation of his stroke.
However, as in real life, multiple orders are placed simultaneously in the hospital for multiple patients. In addition to Frank, who is in the ER, we have a patient who is in the neuro ICU, and her name is Joan. She also experiences altered mental status at the same time Frank presents to the ED. Joan's ICU neurologists order a stat MRI to investigate.
Equium, a smart scheduling and resource utilization platform, receives HL7 messages from Cuvera for both Frank and Joan's MRI orders. Quick aside here about Cuvera. Not many people probably know that although all these tools speak standards like DICOM, HL7, and FHIR, there is still a bit of interpretation that is required. Think of it as if they are speaking with different accents. Same language, but still sometimes hard to understand. They act as translators to ensure that all systems can communicate effectively and make everything just work.
Back to our scenario. Equium's Resource EQ software optimizes scanner resources by predicting optimal scan durations, identifying scheduling gaps, and forecasting delays in available scanners. Based on both Frank and Joan's clinical indication, patient location and status, and current schedule, Equium assigns the ICU patient, Joan, to the Hyperfine Swoop portable MR imaging system. Frank, the ED patient, is sent to the conventional MR scanner. Joan's brain MRI scan is assigned to Hyperfine as Equium calculates that it will be much faster to perform a portable brain MRI scan in the ICU than waiting for transport and nursing availability to take her down to the conventional scanner. A bit about the Hyperfine Swoop portable MR. This allows for point-of-care imaging, allowing timely neuroimaging without delays due to transportation or coordination of clinical staff in a busy trauma and specialty care hospital, especially for our sickest patients. At the time of Joan's order, the Hyperfine Swoop scanner is finishing another post-op brain MRI in the ICU. The Hyperfine MRI is wheeled into Joan's room, and a point-of-care MRI scan is performed with T1, T2, and diffusion-weighted imaging sequences. Meanwhile, Frank has been admitted for observation. The hospital recently implemented Subtle Medical Inc.'s Subtle MR software acceleration protocols, which work with Equium's Resource EQ system to coordinate more frequent scanner time slots owing to accelerated scans. All of the previously scheduled examinations still use the old default 45-minute scan slots for all MRI scans. However, with Subtle MR's denoising algorithm tool in place, scans take place approximately in 45 to 50% less time than standard non-enhanced exams. Equium now forecasts and optimizes the scan slots based on examination type, patient information, and clinical scenario. Equium forecasts Frank's exam to take only 22 minutes. Previously, the addition of the STAT-MR brain would have resulted in pushing back other scheduled exams, resulting in cascading delays. However, a gap is identified to enable Frank's MRI to be scanned with minimal impact to the other scheduled patients.
Images from both Joan and Frank's MRIs are sent to Visage imaging packs for viewing and storage, and to the Bayer AI Orchestrator for AI processing. Bayer AI Orchestrator recognizes the imaging protocols as well as the clinical indication, and Jones' Hyperfine Swoop Brain MR scan is sent directly to the Hyperfine Brain Insight algorithm for further processing. Meanwhile, FrankScan is sent to the Siemens Healthineers AI Rad Companion Brain MR algorithm, which detects acute brain hemorrhages, acute infarctions, acute mass effect. The AI Rad Companion has identified acute infarct on Frank's MR. Because AI Rad Companion has identified a probable acute infarct on Frank's study, the AI results contain a RADLEX code for an ACR Category 1 finding, which means communication and critical decision within minutes of confirmation. Alternative categories include categories 2, requiring notice within hours, and 3, requiring notice within days. The AI results with RADLEX codes are communicated from the AI model to PACS via the AI orchestrator.
This is the Visage reading work list. Since the AI algorithm has noted a high probability of an acute hemorrhage in the patient, as you can see in the Visage system, our patient has been prioritized to the top of the reading work list because of these AI findings. If you hover over this button, you can see Category 1, Emergency Actionable Findings. This prioritization, therefore, may result in better patient outcomes. Up in the ICU, for our patient Joan, the Hyperfine Brain MR Brain Insight algorithm rotates the original MR acquisition so the anatomic landmarks are in the correct position and a new DICOM series is created, resampling from these images. Midline shift is reported on the slice that contains the most significant shift. In this case, Brain Insight algorithm has identified midline shift in Joan's scan. Given the urgency of the scan, the radiologist looks at the study next, which shows that an acute parenchymal hemorrhage is causing Joan's midline shift, ultimately the etiology of her symptoms. At this point, the radiologist has reviewed both Joan and Frank's MRIs, both read in a timely fashion thanks to work list reprioritization, and a report is dictated detailing the acute findings responsible for both Frank and Joan's symptoms.
While in the emergency department, Frank also had a chest X-ray performed as part of the code stroke protocol at his institution. The single AP projection image was sent to Bayer AI Orchestrator, which routes the exam to Cure AI QXR. Cure AI QXR algorithm assesses for the following pathology: pleural effusion, consolidation, nodules, pneumothorax. In this case, a suspicious incidental nodule is identified on Frank's chest X-ray. This is the annotated image, or DICOM, secondary capture. An important thing to note is that AI and radiologists function synergistically. In this case, the algorithm creates a large bounding box in the right upper lung zone. However, there may be more than one nodule within the same region. The radiologist can adjust the report to reflect any additional findings. While AI draws attention to and correctly identifies the presence of pathology, review by the radiologist is necessary to create a clinically accurate report. In this case, the radiologist accepts or rejects AI results shown in Bayer's viewer. Note that in DICOM SR later, you will see more on how radiologists can accept, reject, or modify findings before output is sent to the reporting software. Given the patient's smoking history, the attending physician decides to order a follow-up chest CT for further characterization of the possible lung nodules.
Images from Frank's chest CT are sent via the Bayer AI orchestrator to the MANAI system for analysis.
MANAI is a free and open-source framework for developing and deploying medical AI applications. Founded in 2019 by a community of academic and industry partners from around the world, MANAI provides software development kits for labeling medical data, training AI models, and packaging and deploying AI applications, enabling AI researchers and software developers to take AI from ideation through to deployment. The MANAI app, known as a map in this demo, runs on NVIDIA infrastructure and is delivered via NHS AI Center AID.
The MANAI AI algorithm evaluates the images for nodule detection and lung RAD score calculations. These results are returned to the PACS and the Fovea Extreme AI Cockpit AI Viewer. The algorithm has detected lung nodules, each of which is flagged in the viewer. The radiologist can interact with the AI viewer to select each nodule for review. Once a nodule is selected, the radiologist can either accept or reject the nodule, with the added option to adjust the ruler used to measure each nodule. The Manai algorithm reveals several findings, including our patient's left upper lobe nodule that was initially seen on the chest radiograph. Based on these results, the radiologist can confirm the nodule and proceed to characterize the lesion.
Once results are finalized, the Fovea AI viewer sends confirmed results to M-Modal for report creation using the FHIR standard, which is the newest and greatest interoperable method. Fluency automatically selects the chest CT report template from RadReport. The detected lesions are sent as AI results and are coded as RADLEX values. Once accepted in Fovea's viewer, the existence of nodules auto-populates the report. The location, size, and shape of the nodules is selected to allow the values to be coded and later searchable for precision medicine datasets. These results could also have been dictated. Aside from the nodules, there are no other findings on the chest CT.
Note the paradigm here. In this case, the radiologist can modify AI results before they get into the final report, if they choose to do so at all. In contrast, the report we made for their chest radiograph does not allow us to modify AI results in the final report.
To clarify, SC is static. Once the image is labeled, it cannot be changed. Think about this as a screenshot, meaning annotations may not be removed, and unnecessary labels persist. So, clinicians or radiologists who only see the SC in the future without also looking at the final report may be misled by a preliminary, potentially inaccurate interpretation. On the other hand, SR is dynamic. Annotations to the DICOM can be modified or deleted as the radiologist crafts their final report. This way, providers without access to the report may still receive a final, complete assessment by viewing the SR.
And that brings us to the end of our demonstration. We hope that you consider the following key takeaways. Number one, the architecture of the overall system for your hospital is critical. Number two, requiring international standards such as IHE, DICOM, HL7, and FHIR will enable interoperability. Number three, requiring structured coded semantic systems such as RADLEX, LOINC, and SNOMED will make the AI and other data flow through the system. Number four, you need to ask for all of these in every RFP for every system.
Benefits shown in this demo include smart scheduling and resource utilization based on real-time HL7 messages, clinician orders, and availability of resources. Point-of-care MRI to avoid delays in timely neuroimaging. MR Brain reprioritized work lists for the acute patients, left incidental but non-urgent findings unprioritized. Second reads automatically and on time. No delay of patient care while still receiving input. Automatic detection and, depending on the modality, quantification of lesions to reduce tedious and time-consuming tasks of measuring and entering directly into the report to eliminate dictation of nodules. Of course, keep in mind that the radiologist can change the size of the nodules that the AI detected, as well as edit, remove, and add any other nodules that the radiologist sees fit. They have the final say.
With all of this in mind, the key question is, how do you know if AI is actually improving your workflow at your institution? You can use the IHE Standardized Operational Log of Events, or SOL profile, to help track the impact of AI on your clinical workflow. This dashboard allows for precise measurement of activities in your department. See the graphs over time of SOL in the prostate cancer workup for additional evaluation.
Last but not least, there are two other imaging AI in practice imaging workflow demonstrations using other clinical scenarios with other products. Consider watching all three demonstrations.
Thank you so much for attending RSNA 2022, and we look forward to your presence next year.